Hi, this is Steve Silverstein in Kansas City, Missouri. Let me introduce you to a 71-year-old woman who was referred to me for corneal transplantation due to an unknown corneal dystrophy. The dystrophy her referring doctor discovered was central cloudy cornea of Francois, in which there is a central cloudy zone with a clear peripheral zone of the cornea. Under the operating microscope, it was impossible to have an adequate or safe view of the anterior segment because the columnar light beam is scattered and internally reflected by the dystrophic changes in the cornea. I therefore used the endoscope from the ECP machine used for glaucoma procedures and performing surgery endoscopically using the probe as my second instrument to rotate the lens fragments. I was able to safely perform the surgery in both eyes without needing to perform corneal transplantation, with the resulting visual acuity of 20/25 in both eyes best corrected. What you can see in this video is the deconstruction of the nuclear fragments and the irrigation aspiration. You can witness the stability of both the lens capsule and the iris in this patient, not on a Flomax type product for hypertrophy of the prostate and urinary frequency, which causes floppy iris and iris prolapse, but instead we have a very well-behaved iris with good pupil dilation. Following the removal of the cortex, the intraocular lens is injected into the eye, and seeing this take place endoscopically is quite interesting, as you can see the delivery of the leading haptic followed by the optic, and then after delivery of the lens and removal of the viscoelastic both from the angle, and you can see good quality angle structures, as well as inside the capsular bag, but then underneath the optic, you can, by lifting up the optic-haptic junction, see the way the lens was manufactured. Afterward, it's fun to take a peek around the anatomy and glance at the pars plicata and pars plana before exiting the eye. I find this technology remarkably helpful in patients with corneal pathology that may limit your surgical view from the microscope and therefore otherwise be a much more risky procedure, but instead being able to avoid a more significant surgery such as penetrating keratoplasty, perform an intraocular procedure safely under endoscopic guidance.